Welcome back to the deep dive. Today we are tackling a condition that is, well, it's notorious for its sheer unpredictability. We're talking about Meniere's disease, or MD.
Right, and it's so much more than just feeling dizzy. I think that's the first misconception.
Exactly. This isn't just occasional dizziness. It's a chaotic, fluctuating disorder of the inner ear that can just strike completely without warning.
That's a perfect way to put it, chaotic. If you've heard of MD, you probably think of that crippling vertigo. But it's really a cluster of 4 symptoms. They ebb and they flow.
And what are those for?
So you have those episodes of spontaneous vertigo, you have a measurable hearing loss that often fluctuates, you have tinnitus, that ringing or buzzing, and then a feeling of pressure or fullness in the ear.
It sounds like a clinician's nightmare to study.
Oh, it is, because the severity varies wildly. You have all these different symptoms, and it probably represents a cluster of related pathologies. It's likely not just one single uniform disease.
That's a really interesting point from the sources, that MD might not be one thing. It's like many different roads all leading to the same terrible destination.
Exactly. It's a car-in syndrome. And this lack of a single identifiable cause makes clinical trials just incredibly difficult.
How so?
Well, how do you test a single treatment when the underlying reason might be different from patient to patient? It's really held back our ability to find a unified, evidence-based way to manage it.
So if we're looking for the common thread, the one physiological concept that links all these cases, where do we start?
We have to start with fluid dynamics. The central hypothesis, the one that's most accepted, is that Meniere's is linked to raised pressure in the inner ear fluid.
Right.
This excess fluid is a state known as endolymphatic hydrops. And pretty much everything we're going to talk about today, from diagnosis to treatment, it's all built around trying to manage the effects of that excess fluid.
Okay, so let's unpack that. Our mission today is to give you a shortcut to understanding this highly complicated condition. We are diving deep into how doctors define it, the competing theories for what causes the attacks, the stages it goes through, and crucially, that stepwise path from lifestyle changes all the way to surgery. So because MD is so internal and cyclical, the diagnosis is primarily clinical. That means it really comes down to the patient's own story. How do clinicians bring some order to that subjective chaos?
We lean very heavily on the official guidelines, specifically the American Academy of Otolaryngology Head and Neck Surgery, or AAO-HNS 2020 guidelines. They're the cornerstone.
And what do they do?
They categorize MD into different levels of certainty. So you can go from probable, which is a strong suspicion, to definite, where we have some objective data, all the way to historical certain status.
Okay, let's focus on that pivot point. The difference between definite and probable MD. What is the one piece of evidence you absolutely need to have to say it's definite?
The distinction hinges entirely on audiometric documentation, a hearing test. To be classified as definite Meniere's, you have to meet 4 criteria. First, at least 2 separate spontaneous episodes of vertigo. And these aren't just little dizzy spells. We're talking 20 minutes up to a full 12 hours.
Wow, so true. Spinning, incapacitating vertigo.
Precisely. Second, and this is the key, at least 1 episode of audiometrically documented sensorineural hearing loss. You have to have it on paper from a hearing test. Third, they have to report tinnitus or oral pressure in that same ear. And fourth, and this is non-negotiable, you have to have rigorously excluded all other possible causes.
That documented hearing loss seems to be the linchpin. Why is that one piece of data so vital for the definite classification?
Because it's the only objective way to measure the disease's effect on the cochlea, the organ of hearing. I mean, vertigo is subjective, right? Tinnitus is subjective.
Yeah.
But a hearing loss on an audiogram, that is objective proof that the underlying problem, the hydrops, is physically impacting the inner ear. Historically, absolute certainty was only possible after death, by looking at the temporal bone under a microscope to see the hydrops. The definite definition is our best attempt at that certainty in a living person.
That really puts it in perspective. So what if you have all the other symptoms, the awful vertigo, the tinnitus, the pressure, but you happen to see the doctor on a good day when your hearing has bounced back to normal? What then?
That's a great question, and that's exactly where the probable MD classification comes in. It acknowledges how much this disease fluctuates.
Okay.
For probable MD, the patient needs those 2 episodes of vertigo, again, 20 minutes to 12 hours, and the tinnitus or oral pressure. Other causes are still excluded. The key difference is just the absence of that documented, measurable hearing loss at the time of the test.
That makes sense. So you don't dismiss patients just because you couldn't catch the hearing loss on a test.
Exactly. It's a very practical classification.
Now, relying so much on the patient's story suggests you might want a quicker tool, something purely clinical to sort of quantify your suspicion before you do all the big tests.
Absolutely. And that's where something called the Gibson 10-point score is really useful. It's a pragmatic numerical tool. It's not about classifying, but more about gauging the likelihood of MD based purely on the patient's history.
So how does that scoring work? Is it just a checklist of symptoms?
It's a bit more clever than that. It rewards the combination of symptoms, which is really the signature of this disease. For example, you get points just for having rotational vertigo, but you get a bonus point if that vertigo happens at the same time as hearing loss or tinnitus or pressure.
So if the patient says, when the world starts spinning, my ear starts ringing and I can't hear, that score is higher than just the spinning alone.
Correct. The simultaneous symptoms are a massive red flag. The same logic applies to hearing. You get points for the loss itself, more points if it fluctuates, and so on. It looks at the whole picture.
And is there a threshold, a score that makes a doctor think, okay, this is very likely Meniere's?
Yes. A score of 7 or more out of 10 is considered highly suggestive. It's a really good way to quantify that clinical suspicion before you move on to the more objective workup.
Okay, let's shift from diagnosis to the actual mechanics. This is where it gets really interesting. We know the central issue is this endolymphatic hydrops, this excess fluid pressure. But why does the pressure rise in the first place? And how does that pressure suddenly turn into an hours-long, disabling vertigo attack?
To get this, we need a quick anatomy lesson. The inner ear is this complex, fluid-filled maze inside the temporal bone, and it has two different fluids, perilymph and endolymph.
Okay.
Think of them like two separate plumbing systems running right next to each other. Perilymph is rich in sodium, like normal fluid outside of cells.
Mhm.
Endolymph, on the other hand, is really unusual. It's super rich in potassium.
And these fluids are kept separate.
They are, by these incredibly delicate membranes. The hearing part, the cochlea, has this central duct called the scala media, and that's where the endolymph lives. And in hydrops, studies of temporal bones have confirmed that this scala media is visibly swollen, expanded by all that extra fluid.
So at its core, MD is a fluid imbalance problem,
Yes.
specifically with this potassium-rich endolymph.
Yes. But, and this is a really critical caveat, while hydrops is almost always there in affected ears, we don't fully understand its precise role. You can actually have hydrops and be completely asymptomatic.
Really?
Yeah, which strongly suggests that MD is probably a variety of different underlying issues. Maybe it's autoimmune, maybe viral, maybe mechanical,
Yeah.
that all just funnel down into this common pathway of producing hydrops. Something else has to be the trigger for the attack itself.
So before we get to that trigger, what's supposed to keep the fluid in balance normally? The etiology.
It's a really sensitive, localized system. The volume is regulated by complex ion transport, all under hormonal control. But the most important structure for pressure regulation is the endolymphatic sac.
What does that do?
It acts kind of like a relief valve or a drainage point for the endolymph. If anything goes wrong with that sac or the systems that control the fluid, you get a backup. You get hydrops.
Okay, so that brings us to the pathogenesis, the crisis. The pressure is building, and then suddenly an attack begins. I know there are two main theories here. Let's start with the older one, the rupture theory.
Right. The rupture theory is pretty intuitive, but it's generally fallen out of favor. It proposes that the pressure in that scala media gets so high that it literally ruptures the delicate membrane separating the endolymph from the perilymph.
That membrane is called.
Reisner's membrane.
So if that membrane breaks, what happens when those two very different fluids mix?
It's a catastrophe. That flood of high potassium endolymph is basically toxic to the sensory hair cells for hearing and balance. The theory suggests this toxic mix instantly paralyzes them, causing the vertigo and the hearing loss until the membrane somehow repairs itself.
That sounds plausible, but you said it's been heavily critiqued. What's the biggest problem with the rupture theory?
There are two big flaws. First, the evidence for these ruptures came from postmortem specimens, and modern researchers think those were probably just artifacts from preparing the slides. It's not like the person died mid-attack.
Okay, that makes sense.
But the bigger problem is anatomical. Early hearing loss suggests hydrops starts at the apex of the cochlea. If a rupture happens there, how does that localized event instantly cause severe rotational vertigo in the balance organs, which are anatomically quite far away? The connection is just, it's weak.
It fails the distance test. So that brings us to the more accepted theory, the one that solves that distance problem. The drainage theory.
Exactly. The drainage theory is mechanically a lot more sophisticated.
Right.
It focuses on how the pressure regulation system fails.
So how does the attack work under this theory?
So as the endolymph volume builds up, the excess fluid tries to drain out of the cochlear duct through the saccule and into a small collection point called the endolymphatic sinus. The crisis happens when the volume of fluid overwhelms the capacity of that sinus. The pressure builds and builds until it breaches a delicate valve, the barrier separating the sinus from the main balance chamber, the utricle.
So it's not a tear, it's more like a dam bursting. A valve gives way. What happens when that fluid rushes into the utricle?
Well, the utricle is the central chamber of the vestibular system. It connects directly to the 3 semicircular canals. So this rapid, unnatural overflow of endolymph violently stretches the sensory organs within those canals, the cristae. And that sudden, massive stretching and distortion is what the brain interprets as a debilitating vertigo attack.
That makes so much more sense anatomically. The fluid doesn't have to poison the whole system, it just has to flood the balance machinery. Does this theory also explain the eye movements, the nystagmus, that you see during an attack?
It explains it beautifully. During an attack, we often see a progression. The initial rush of fluid in likely causes an irritative nystagmus, where the eyes beat towards the affected ear. But then as the fluid settles or flows back out, the system shifts, and you get a paralytic nystagmus, where the eyes beat away from the ear. The drainage theory maps the fluid dynamics directly onto the clinical signs we see.
The dynamic nature of MD is one of its hallmarks, right? It's not a static thing. It evolves, often, over many years. Let's chart that progression through the 3 typical stages.
Yeah, you can really think of it as a slow march from acute, catastrophic vertigo attacks towards chronic permanent deficits in hearing and balance.
So let's start at the beginning, stage 1, the onset. What does life look like for a patient in this stage?
Stage 1 is all about the vertigo. The attacks are severe, incapacitating, often with intense nausea and vomiting. But the key feature here is that between the attacks, the system fully recovers.
You mean everything goes back to normal? The hearing, the tinnitus, the pressure?
Everything. The hearing fluctuates, but it returns to normal thresholds. The tinnitus and fullness often disappear completely. So if a clinician sees a patient between attacks in stage 1, all the tests, they can be frustratingly normal.
So stage 1 is defined by the system's ability to reset. What marks the shift to stage 2? Repeated episodes.
The transition to stage 2 is marked by cumulative damage.
Yeah.
The vertigo attacks continue, but now the system is losing its ability to fully recover. The hearing might still fluctuate, but it does not go all the way back to normal. There's now a permanent, measurable hearing loss.
So the baseline hearing level just keeps getting worse over time.
Exactly, and this is the stage where the tinnitus and oral fullness often become constant companions, even between attacks. It tells you there's a chronic underlying state of high drops that's always there.
And finally, that brings us to stage 3, the burnt-out phase. This sounds, well, it sounds like the quiet after the storm, but where the house has been destroyed.
That's a good analogy. In stage 3, the vertigo is often the least problematic symptom. The disease is burnt out because the structures that cause those dramatic attacks are now largely damaged. But the hearing, while it stabilizes at a very poor level, often around 60 decibels.
Can you put 60 decibels of hearing loss into context for us?
Sure. A 60 dB hearing loss is severe. Normal conversation is around 50 to 60 dB. So at that level, you would struggle to follow a conversation unless someone was shouting. It's a very socially isolating level of hearing loss. And in this stage, the tinnitus and oral pressure are constant.
And it's in stage 3 where we see that rare but absolutely terrifying complication, the Tamarkin drop attack. We should probably spend a moment on this.
We should. It's arguably the most frightening symptom. A Tamarkin drop attack is a sudden, violent fall that happens with absolutely no warning. The key thing is the person doesn't lose consciousness. They're just 1 second standing, the next second on the floor.
That is horrifying. What's the mechanism behind that?
It's thought to be a sudden, massive pressure change that specifically affects the otolethic organs, the saccule and utricle, which sense gravity. This pressure shift causes an instantaneous, catastrophic failure in their sense of where down is, leading to an abrupt loss of muscle tone. The psychological impact of living in fear of that is, well, it's immense.
Given how much this disease fluctuates and how serious the treatments can be, objective testing must be vital. You need to find some evidence of that high drops.
Absolutely. And we start with the foundation, which is pure tone audiometry, PTA, the hearing test. It's essential for documenting the loss and, critically, for tracking that fluctuation over time.
Is there a specific pattern of hearing loss in the early stages that points towards MD?
Yes. Early on, the hearing loss often affects the lower frequencies. And this is a key finding because it supports the theory that eye drops start to the apex of the cochlea, which is where those low frequencies are processed. Documenting that specific pattern is huge for getting that definite diagnosis.
Okay, let's move to balance testing, caloric testing. How does this help map out the stage of the disease?
It gives us a really clear functional map. In stage 1, caloric testing, which measures the function of the lateral semicircular canal, is usually normal. But as the disease progresses into stage 2 and then the burnt-out stage 3, we see a clear decline, often a 50% or more reduction in function on that side.
You mentioned before how crucial it is to test the unaffected ear before any destructive treatment. Could you explain the concept of becoming a labyrinthine again?
Yes, this is a critical safety check. When we consider a treatment that destroys the balance function in the bad ear, like a gentamicin injection, we absolutely have to know how good the good ear is. If that other ear has some hidden weakness and we destroy the function of the diseased ear, we can leave the patient with no functional vestibular input from either side.
And that's being a labyrinthine.
That's it. And it results in constant severe imbalance and a visual problem called oscillopsia, where the world seems to jump and shake whenever you move your head. It's a catastrophic outcome that we have to prevent.
Okay, now let's get into the more specialized tests, starting with electrocochleography, ECOG. In simple terms, what is this measuring?
ECOG measures the electrical signals generated by the cochlea and the auditory nerve when you hear a sound. It's like taking an electrical snapshot of the inner ear at work.
And how does eye drops change that electrical snapshot?
The fluid pressure and distortion from eye drops messes with those signals. Specifically, it significantly increases the size of one component, the summating potential, SP, relative to another, the action potential, AP. So we look for an increased SP to AP ratio.
But the sources say that using that ratio alone can be unreliable, especially early on.
That's right. The early studies had high specificity. If you saw it, it's probably MD, but poor sensitivity. It missed a lot of early cases. It wasn't accurate enough.
So how did they improve it?
They realized they needed to focus just on the SP itself because research shows that the more eye drops you have, the bigger the S key gets. So the refined technique uses a specific sound, a one-colored tone burst stimulus, to get a better look at the SP, which has really increased the accuracy for detecting eye drops in those early stages.
Okay, next up is vestibular evoked myogenic potentials, or VEMPs.
Sure.
A newer tool that I hear it's promising. What part of the anatomy does this test?
VEMPs test the function of the otolithic organs, the saccule and the utricle. And this is directly relevant because they're right in the middle of the action in MD. We use two types. The cervical VEMP, CVEMP, which mainly tests the saccule, and the ocular VEMP, OVEMP, which mainly tests the utricle.
And why is that distinction so important for Ménière's?
Because the evidence shows that MD is characterized by dominant saccular eye drops. The saccule seems to be the most affected otolithic organ, so the CVEMP, the test for the saccule, has shown the greatest specificity for diagnosing MD. It's testing the most vulnerable part.
And what's the key finding you look for?
We look at the intraoral amplitude difference, IAD. We're comparing the size of the electrical response between the two ears. That difference is the most consistent and useful finding for highlighting the weakness caused by eye drops, even in the early stages.
Now let's talk about the real game changer, magnetic resonance imaging, MRI. Its initial role was just to rule out other things, but now we can actually see the eye drops. How is that even possible?
It's possible because of a contrast agent called gadolinium. The trick is getting it into the right place at the right time. It can get into the paralymph, the sodium-rich fluid, but it has a hard time getting into the endolymph, the potassium-rich fluid where the eye drops is.
So you can see the boundary between them.
Exactly. It allows us to map the inner ear compartments.
And I know there are two ways to get the gadolinium in there. What are they?
The first was transympanic gadolinium. It's invasive. You actually inject it into the middle ear, it diffuses in, and you do the scan 24 hours later.
And the newer, more popular method
is intravenous gadolinium, much less invasive. A high dose is given through an IV, and you scan 4 hours later. It's much better tolerated, and, crucially, it lets you scan both ears at the same time for comparison.
And what does the eye drops look like on that final image?
You're looking for what we call a filling defect. The gadolinium fills the paralymph space, so the swollen, expanded endolymph space. The eye drops shows up as a dark area where the contrast didn't go. This is revolutionary. It allows for a premortem identification of eye drops. This is very likely going to be the tool that lets us achieve a certain diagnosis in living patients.
Okay, so once that diagnosis is established, maybe even confirmed with that advanced MRI, management becomes this very precise, stepwise affair. And the goals are what? preserving hearing and controlling the vertigo.
Exactly. And always keeping in mind the risk of it becoming bilateral, affecting both ears, which can happen in up to 50% of patients.
Yeah.
That high risk really forces you to be cautious about any destructive treatments.
So you start minimally invasive and only escalate when you absolutely have to.
That's the mantra.
Okay, so let's start with the first line defense, lifestyle changes. What's the single most important thing a patient is told to do?
It's diet, specifically salt restriction. The theory is that high sodium leads to fluid retention, which can increase the endolymph volume. The recommendation is pretty strict, less than 1.5 to 2 grams of salt per day,
And beyond salt.
avoiding known triggers, alcohol, caffeine, and especially tobacco. And then there's stress. Stress reduction is often overlooked, but it's critical. It's a recognized factor that can trigger attacks.
Okay, so if lifestyle changes aren't enough, you move to medications. What's the main drug used for prevention?
The workhorse is a drug called beta-histine. It's thought to work by dilating the small blood vessels in the inner ear, improving circulation, and hopefully fluid dynamics.
But I remember you mentioned a paradox here. It's used everywhere, but the evidence from specific MD trials is shaky.
It is. It's a classic case of real-world use versus controlled trials. In general vertigo populations, it seems to work. But in very specific, rigorous trials on just Ménière's patients, the results are often no better than placebo.
So why is it still used so much?
Because patient response is so variable. For some people, it's a miracle drug. For others, it does nothing. And because it has a very low side effect profile, it remains a very common second-line medical treatment.
What else is in the medical toolbox?
Diuretics are the other key one, thiazide diuretics. The idea is to reduce the overall body fluid load, hoping that lowers the pressure in the inner ear. And then for the acute attack itself, we use anti-nausea meds and vestibular suppressants like prochlorperazine to manage the awful vomiting and vegetative symptoms.
So if all that medical management fails, we have to consider surgery. And the choice of what to do next hinges entirely on one question. Does the patient have socially useful hearing? How do you define that?
Typically, it's defined by a speech discrimination score of greater than 50%. If you can still understand more than half the spoken words, we consider that serviceable hearing, and we do everything we can to preserve it. If hearing is already poor, then destructive options become more justifiable.
Okay, let's compare the strategies then. What's the first-line surgical intervention?
For both groups, whether they have good hearing or bad, the first surgical step is an intratympanic injection of steroid. We inject something like dexamethasone right through the eardrum. It's a potent anti-inflammatory, and it often works really well to control vertigo without destroying anything.
A great low-risk first step. But if that fails and the patient still has that serviceable hearing, what's next?
That brings us to the famous and quite controversial endolymphatic sac surgery, ELS. The goal here is to decompress the endolymphatic sac, that pressure release valve we talked about, to help it work better.
Why is it so controversial?
Because the evidence for it is very mixed. The most famous study compared it to a sham surgery, where they made the incision but didn't actually touch the sac, and found that the sham surgery was often just as effective.
Wow, so it could just be a placebo effect.
It's possible. Many believe its success is due to placebo or just the natural ups and downs of the disease. But many experienced surgeons still find it works for a subset of patients. And because it's non-destructive, it remains a viable second-line option to try to save hearing.
Okay, now let's flip to the other side. The patient with non-useful hearing who fails steroids. What's their second line?
If hearing is already gone, we often move to a more definitive destructive measure, which would be a total osseous labyrinthectomy. We'll get to what that entails in a moment.
Okay. Now for the third line, the truly ablative phase. Let's go back to the patient with serviceable hearing but intractable vertigo. You have to destroy the balance function but try to save the hearing.
This is where we use an intratympanic injection of gentamicin. Gentamicin is an ototoxic antibiotic. It's toxic to the inner ear. But crucially, it's more toxic to the vestibular hair cells for balance than it is to the cochlear hair cells for hearing.
So it's a kind of controlled chemical destruction. How do you monitor that?
Very, very carefully. We give low-dose injections weekly, and we stop immediately if the vertigo resolves, if new balance symptoms appear, or if we see any drop in their hearing. It's effective about 80 to 90% vertigo control, but it's a delicate balance.
What if you need absolute control but still want to preserve hearing? The ultimate option.
That would be a vestibular nerve section. This is major neurootological surgery. The surgeon goes in and physically severs the vestibular nerve, but meticulously spares the adjacent cochlear nerve. It gives you 95% plus vertigo control while preserving hearing, but it comes with the risks of major intracranial surgery.
And finally, the most destructive procedure of all for absolute failure, especially for those tumor and drop attacks, total osseous labyrinthectomy.
This is the last resort. It's for patients with no useful hearing who have failed everything else. It results in complete, profound deafness in that ear. The surgeon goes in and physically removes all of the vestibular sensory tissue, the semicircular canals, the saccule, the utricle. You are trading the vertigo for permanent deafness and total reliance on the other ear. We have a case study here that just perfectly illustrates this whole stepwise approach, always putting hearing preservation first.
Let's hear it. Tell us about this 42-year-old patient. What was his journey?
He presented with a classic stage 1, maybe early stage 2 picture. A 6-month history of intermittent right-sided fullness, severe rotatory vertigo for hours at a time, tinnitus, and the key fluctuating hearing loss. All the tests confirmed it.
So, a clear case of definite MD. What was step one for him?
Step 1, medical and lifestyle. The team started him on a strict salt-free diet, lifestyle changes, and beta-histine, and that gave him some initial temporary control.
But the vertigo came back, and he still had serviceable hearing, so preservation was the top priority.
Exactly. So for step 2, they escalated, but non-destructively. They moved to that first-line surgical intervention, a transtympanic injection of a steroid, dipomedrone, into his right ear.
And what was the outcome of that?
It was successful. His severe vertigo spell settled down, and his hearing stabilized, which was huge, prevented more cumulative damage. But he was left with some residual intermittent unsteadiness.
A common side effect of a compromised vestibular system. How is that managed?
That was managed with the final step. Vestibular rehabilitation therapy, or VRT. It's a specialized physical therapy that trains the brain to use visual and other sensory cues to compensate for the weak inner ear. It's often the last piece of the puzzle.
That case just perfectly shows the goal. Control the chaos, mitigate the loss, and only destroy as a last resort. Looking forward now, what research holds the most hope for these patients?
There are two really exciting frontiers. First, for patients who end up with bilateral disease and profound hearing loss, cochlear implantation is now offering really effective hearing rehabilitation. That's a huge step forward on the hearing side.
And on the balance side, which has always been the hardest part to treat.
That's where the most advanced research is. Implantable vestibular devices. Think of it like a cochlear implant for balance. These devices would electrically stimulate the vestibular nerve to restore function.
Wow.
They offer the prospect of not only controlling the vertigo attacks, but also rehabilitating the underlying weakness, which could offer much better long-term balance stability than just destroying the system.
This has been an incredibly detailed look at Ménière's disease. We defined it by its 4 cardinal symptoms, and we detailed the crucial difference between definite and probable MD, really highlighting how essential that objective hearing test is.
We connected it all back to endolymphatic eye drops, and we contrasted that old unlikely rupture theory with the much more convincing drainage theory, linking the vertigo to that overflow of fluid into the balance organs. We then charted the 3 stages, seeing how the disease shifts from violent vertigo to a chronic burnt-out state of hearing loss.
And we dove into those sophisticated objective tests, from simple audiometry to ECOG and VMPs, and then that revolutionary gadolinium MRI, which for the first time lets us actually see the eye drops in a living person.
And we saw that the management is this precise, stepwise process, all dictated by how much hearing the patient has left. It's a constant balance between non-destructive options like steroids and ELS surgery against the need for ablative treatments like gentamicin, always with that risk of bilateral disease in mind.
To me, what stands out most is just the sheer evolution of the disease. It's this tragic progression from sudden, violent attacks to a chronic state of permanent loss and instability.
It truly is a marathon of degradation. And here is the final provocative thought I'd like to leave you with. Given that high rate of bilateral disease, up to 50%, and our new ability with MRI to actually see eye drops, how dramatically will the management of MD change once we can routinely identify eye drops in the contralateral ear, the good ear long, before it ever causes any symptoms?
You mean treating it before it even starts?
Exactly. If we could treat the pathology prophylactically, the entire prognosis for patients with Ménière's disease could be completely revolutionized.